Hi, everybody. This is Dr. Brett Talley Daniel, MD, and I'm a neurologist and headache doctor. This podcast is going to be on dihydroergotamine, or what's called DHE for migraine. Okay, so ergotamine blocks serotonin receptors and causes constriction of arteries, vasoconstriction. It was first used in the 16th century to induce childbirth by causing constriction of smooth muscle in the uterus, and then later is used for migraine in 1925. Ergotamine for acute therapy of migraine had its heyday from the 60s till the 90s when Imitrex 6 milligrams subcutaneous injectable first came out, but it's rarely used now for acute migraine therapy. A progeny of ergotamine is dihydroergotamine, DHE, which was first produced in the United States in 1946. DHE blocks serotonin receptors and causes constriction of cranial blood vessels, but mainly veins, and it has a long half-life of about 9 hours. DHE has been used as the go-to acute migraine medication for patients taking too much headache medicine who get medication overuse headache. I have articles on this on my blog page at www.drmigraine.com/medication overuse headache. You could read. All across America, major hospitals have headache neurologists who admit patients with chronic migraine for IV DHE treatment. DHE can be given intravenously, intramuscularly, subcutaneously, and as a nasal spray, but it's not available orally. So the question today is, does DHE work for migraine? Yes, it works for acute therapy for regular migraine headache, and is used all over the world for patients who overtreat with NSAIDs, triptans, over-the-counters, opioids, and butalbital drugs. Headache doctors instruct their patients to either quickly or slowly stop overtreating with medication and switch over to DHE, which will usually cover the headache but not cause headache. All right, so what's the pharmacology of DHE? For acute migraine and cluster headache treatment in adults, it may be given 1 milligram subcutaneously, intramuscularly, IV once with a maximum of 3 milligrams every 24 hours, or subcutaneously and intramuscularly up to 6 milligrams a week, or 2 milligrams every 24 hours IV for up to 6 milligrams a week. And you can repeat the dose every 1 hour within those limits. Parenteral, or which means injectable treatment, is usually given at the hospital, and there's a program for 5 days of hospital admission with IV DHE treatment that may be given to certain patients. Intravenous DHE injection is usually very effective for severe, frequent migraine headaches, or what is called status migrainosus. Pediatric doses is currently unavailable and not applicable for this drug. DHE can also be given by nasal spray called Migranol, which is about 1/6 as strong as parenteral treatment. And it goes nasal spray. However, it's usually effective and a great relief to those who can't learn to give themselves a shot or who have needle phobia. However, if a patient doesn't respond well to nasal spray DHE, they can then inject with the intramuscular dose because it's stronger. One study found that 61% of Migranol patients experienced relief by 2 hours, and 86% of responders had no recurrence at 24 hours. An important point is that DHE should not be used within 24 hours of one of the triptans, like Maxalt or sumatriptan, Imitrex. Patients may use Migranol nasal spray and intramuscular DHE at home and usually don't need to be admitted for hospital for further treatment. Oral bioavailability is poor, and it's not available for oral form in the United States. Are there any serious side effects of the drug? Well, DHE has a black box warning for causing serious and or life-threatening peripheral ischemia of limbs or cerebral ischemia. Nausea is a common side effect of IV administration and less common in other modes. But antiemetics, anti-nausea drugs, can be given prior to DHE to counteract the nausea. Risks and contraindications are similar to the triptans. DHE and triptan should never be taken within 24 hours of each other due to the potential for coronary artery vasospasm. DHE produces no dependence. Rare, milder side effects may be nausea and leg cramping. So what are the typical use of DHE and Migraine? Migraine nasal spray may be used for outpatients with medication-induced headache, where they may need it for several weeks while they detox from all the painkillers they've been taking, and they need something for episodes of acute headache that won't worsen their situation. It may also be used for patients who get in trouble taking triptans more than 2 days a week and develop short-term medication-overuse headache, like daily headache for 5 or 6 days. The International Classification of Headache Disorders, version 3, requires overtreating for 3 months to make a precise diagnosis of medication-overuse headache, but many patients have problems with shorter terms of overtreatment, like several weeks or even a month or days. Some patients are helped by limiting triptan use to 2 days only, and all migraine patients are supposed to do that anyway, only 2 days a week, and then take DHE for a third headache day in a week, as long as it's 24 hours since they've taken a triptan. Patients like this need to be doing the migraine lifestyle and consider getting on a preventive drug. And after they get back into episodic migraine, some patients refer DHE nasal spray over triptans, and they just stay on that treatment. Using DHE this way, I very rarely have to admit patients with headache, but can manage most of them in the office or as outpatients. DHE mechanism of action. DHE's anti-migraine activity is due to its action as an agonist to the serotonin 5-HT1B, 1D, and 1F receptors. It also interacts with other serotonin, adrenergic, and dopamine receptors. Contraindications of DHE. Well, it's contraindicated for pregnancy, breastfeeding, severe renal or hepatic impairment, ischemic heart disease, uncontrolled hypertension, peripheral arterial disease, basilar or hemiplegic migraine. So DHE availability. It's available as a nasal spray and ampules for subcutaneous, intramuscular, and intravenous injection. The efficacy is variable in the nasal spray form, with bioavailability about 32% of injectable administration. Next, I'm going to go over some medical articles that have recently been published on the use of DHE for migraine. One of them comes from Andrew Josephson. He wrote in Medscape in March of 18th of 2020. The title was "A Long Course of Intravenous Dihydroergotamine Likely Effective for Refractive Headaches." And he comments that for 3 decades, IV DHE has been an option for treatment of refractory migraine in both emergency and inpatient settings. Nagy and colleagues in 2011 examined a large series of cases using IV DHE for a variety of headache conditions and in a more prolonged dosing schedule in order to report a contemporary experience with this drug. So the Josephson articles retrospectively interviewed a population of 163 of the 446 patients treated with IV DHE over a 5-year period at a single institution in London. The diagnosis treated included chronic migraine in 114, cluster headache in 38, and new daily persistent headache in 11. One patient had both a migraine with R and new daily persistent headache. Patients were treated with an IV DHE inpatient protocol that included 5 days of treatment with a goal cumulative doses of 11.25 milligrams, with a range of 8.25 to 11.25 total dose for the 5 days of treatment. Severe nausea, a known side effect, was treated with a variety of antiemetic medications. A total of 74% of the patients with migraine reported benefit, half of which was rated as moderate or excellent. A total of 67% reported headache freedom during the treatment, and 75% achieved freedom within 1 month of therapy. The effect of this therapy on these patients with medically refractory migraine lasted an average of 28 days. All of the treated patients were advised to and did halt their medication overuse habit, including that of narcotics, a primary reason why some have advocated admission for IV DHE therapy in the past. In terms of disability, 25% reported less time off work following treatment, and 50% reported increased activity. Patients who had migraine with aura had no appreciable difference in the results compared with those without aura. A total of 84% of the patients with cluster headache reported headache freedom during the hospitalization for IV DHE treatment, and the mean time to return of attacks was 17 days. Of the 11 patients with new daily persistent headache, only 2 reported a mild benefit with the treatment. In the entire cohort, the largest predictor of achieving a pain-free state in a logistic model was increasing DHE dose. Greater amounts of nausea despite treatment with antiemetics was a predictor of failure to become pain-free. The most common adverse event was nausea, which was reported in 94 patients and led to cessation of IV DHE treatment in 6. Other common adverse events were leg cramps and need for replacement of the peripheral IV. No cardiac effects, including EKG changes, were found. The authors said, in summary, DHE is an effective therapy that can be considered in patients with refractive headache disorders, including cluster headache. Interestingly, the author said some of the patients achieved their pain-free state in a delayed fashion following discharge, which suggests that physicians should counsel their patients that the goal of IVDH therapy is not to achieve a pain-free state during the actual admission, but rather that some effects will be achieved only after discharge and may be long-lasting. The other article I have for perusal to look at would be one by Ford, and Ford published in Headache in 1997. And the title is Continuous Intravenous Dihydroergotamine and Treatment of Intractable Headache. And I reviewed the abstract there. They had 171 patients with refractory headache treated with continuous IV DHE treatment. And they compared it with giving it continuously or giving it repetitively. So they had 100 patients had refractory chronic daily headache. 71 patients had drug rebound headache. 138 had refractory migraine without aura, and 28 had migraine with aura. Treatment consisted of either continuous IV DHE by infusion, pump, or repetitive. DHE and withdrawal of excessively used analgesic narcotics, ergotamines, or benzodiazepines. 89 patients treated with continuous IV became headache-free. The majority, 62, within 3 days, and 85 patients repeated by repetitive became headache-free within 3 days. The average hospital stay for both treatment groups was 4 days. 12 of the continuous group and 12 of the repetitive group were headache-free within 24 hours. The average length of time to become headache-free was similar with the two drugs. And again, the most common side effect was nausea followed by diarrhea, vomiting, and leg cramps. So the author concluded that DHE can be accurately and easily administered by continuous infusion pump, and that continuous DHE is a safe and efficacious mode of treatment, producing results similar to IV DHE. So these are great stories and report on DHE, and I'm going to make a personal comment myself. I think it would be hard to practice headache medicine without using DHE. In the United States, starting about 2016 and through 2018, however, it was unavailable for doctors to use. No reason was ever given for this. And that's when we had to develop other drugs that were reported. We had other articles that are published, like the National Headache Foundation had articles that we could use for treating headache, which I had really never used before. We used timolol eye drops, promethazine, quetiapine, olanzapine. The last three drugs are drugs for psychiatric treatment because of their effect on dopamine agonists, and timolol is a beta blocker eye drop that's indicated for glaucoma. Remember that in the world, the real world, 89% of visits to a headache practice are patients with medication-induced headache, even though medication-induced headache is only about 3% of headache worldwide. It's great to have such a drug as DHE to treat these difficult patients. So I appreciate it if you click on the subscribe button. If you want to look at this on my webpage, www.drmigraine.com, I have articles written on that and medication-induced headache. And good luck, and God bless all you patients with migraine. I'll see you again on another talk.